Thanks, Marianne, and thanks for asking us to present today. I'm very happy because for the first time, most of the presentation is going to be done by Junine because I get the easy part doing HIV drug interactions, and Junine will take you through everything else. These are my disclosures, very similar to Richard. A number of speaking engagements for a number of companies. Junine has no conflicts to declare. You've heard a lot about hepatitis C today, first this morning with the unveiling of the new pharmacare guidelines, which we're very excited to be putting into place, and now recently from Richard in terms of some of the drug resistance issues. We're going to focus ourselves on drug-drug interactions, a very important clinical decision to be made sometimes in terms of choosing either HIV regimens or looking at other medications that patients might be on when you're starting to move forward to treat their hepatitis C from a clinical standpoint. I think we have to remind ourselves why we're actually doing this. I think one of the most important things you have to recognize, and this data is from some co-infected studies, but the data exists for mono-infection, perhaps more strikingly so, that achieving an SVR, in other words, eradicating hepatitis C virus from your system, really does have a huge benefit in terms of long-term morbidity and mortality. We have to keep that goal in mind. And this applies whether you have F2 fibrosis. This is more striking if you have F3 or F4 fibrosis. So really, I think unless the patient is decompensated where you need additional support from some of the hepatology teams, you really do need to start thinking of treating your patients when they hit criteria of F2 or higher. The reason really now should be why not to treat as opposed to trying to find reasons to persuade somebody to go on to treatment. We've looked a lot at the viral life cycle. Richard has taken you through some of the drugs, but I think what I like to say to students is you have to picture this now the same as HIV. We can combine direct-acting antiviral targets the same way as we do for HIV therapy. And so for HIV patients, I found they actually find it a very easy concept to grasp because they're used to this idea from their own medications. And so we've spent the last 2 years using these agents here, the NS3/4A protease inhibitors, Telaprevir, Boceprevir, Simeprovir, as Richard has pointed out, and I think it's always worth repeating because it's a helpful memory trick. These drugs end in EVIR, so you can always look smart if you see it on paper and you're like, oh, I know where that drug target is. The next ones that we're starting to use now are some of the NS5A inhibitors, affecting replication and assembly of the virus. And finally, the new target, the NS5B polymerase inhibitor, which is Sofosbuvir, ending in a UVIR. So a lot of new targets that we can now combine together. The initial ones that we had to be added on top of PEG and interferon and ribavirin, and so again, a rate-limiting step for a number of patients, which is meeting the side effect profile of being able to tolerate PEG interferon. As you heard this morning, these drugs definitely improved our SVR rates up into the 70 to 80% range, so they were a huge benefit to us. But unfortunately, again, as we've heard, there was a fairly limited uptake of these medications over the last few years, predominantly because of the interferon component. In addition, from a co-infection standpoint, and this is where we would have spent a lot of time looking at things, if we use Richard's chart of color coding for HIV drug resistance and apply it here to drug-drug interactions, you can see using these medications was a very limiting factor for us, as a number of HIV medications could not be used for these with our Hep C medications. So luckily, we don't have to worry about these complicated drug interactions with the most recently approved pharmacare regimen. This makes our lives a lot easier from a co-infection standpoint. So here we're talking about Sofosbuvir, Ledipasvir. You've heard a lot about it this morning. It's co-formulated as a single tablet, 1 pill a day, essentially renally cleared. Junine will touch on this a little bit later. But from our point of view, one of the nice benefits of this medication is really there are very, very limited effects to the hepatic system. And so from a practical standpoint, the CYP450 isoenzyme system that we've had to worry about with a number of other medications is not targeted here, which makes it quite clean from a drug interaction standpoint. Similarly for Ledipasvir, our NS5A medication, again, not really targeting the CYP450 pathway, but both these medications are themselves substrates of the drug transporter P glycoprotein, and so medications such as rifampin can reduce drug levels, and obviously combining these medications with rifampin is not recommended. But Ledipasvir can be a weak inhibitor of some of these other drug transporters, where some of the other drug interactions might become potentially possible, and Junine will touch on this shortly. Let's look at the evidence. You heard briefly about ION-4 this morning, a fantastic study that we were able to take part in, for the first time offering patients that had failed on therapy before an option for retreatment. So it was very nice to be able to offer patients access to therapy. You were allowed to be cirrhotic. You could be on antiretroviral regimens, including efavirenz, raltegravir, or rilpivirine. And the outcomes, as you've seen with some of the other studies, were very, very similar to what we're seeing in mono-infected patients. So for the first time, co-infection does not seem to make a big difference in terms of some of the outcomes that we have to look at. So overall, 96% of patients achieved an SVR, and this was fairly similar whether you're treatment naive or treatment experienced, and again, fairly similar based on your cirrhosis status. As you saw from pharmacare guidelines, if you're treatment experienced cirrhotic, they now recommend a 24-week course as opposed to 12 weeks, but this was very, very encouraging data that we saw. So from an antiretroviral standpoint, our job here is actually very easy. There are really no meaningful drug interactions that have been described so far with commonly used antiretrovirals and sofosbuvir. There is a contraindication to being co-administered with dipranavir, but I don't think we have too many people, if any at all, in the province on dipranavir at this point in time. And the drug interaction there basically is a reduction in both sofosbuvir and then sofosbuvir, ledipasvir, and active metabolite levels. So from this standpoint, we have a fairly open slate for the drugs that we would commonly use in terms of NSTIs, so the integrase inhibitors, NNRTIs, and probably most protease inhibitors. There's limited data at this point with use for some of the co-formulated tablets such as alvategravir and cobicistat, but I'm sure that data will probably come down the road. The one tricky aspect that we have to think about if we're looking at antiretroviral use in this context is there's some evidence that sofosbuvir and ledipasvir will actually boost tenofovir exposure. So sofosbuvir ledipasvir will increase your tenofovir exposure to a similar extent as has been seen with combinations with HIV protease inhibitors. So if we look at the product monograph, what we see there is we see that use with some agents such as efavirenz can increase your tenofovir levels. And in this context, for the 12-week course of therapy, you have to consider monitoring patients more closely for tenofovir adverse events. And then when we get down to the HIV protease inhibitors, again, we're probably going to see quite a bit of extra tenofovir exposure because the HIV protease inhibitor is increasing the level, and now we're adding sofosbuvir ledipasvir, which is probably doing the similar thing. And the product monograph suggests to us here that we have two potential possibilities. One, if possible, consider an alternative backbone. In other words, switching them during the time that they're going to be treated to an alternative backbone. Or again, accepting that there's going to be increased tenofovir exposure, but hopefully for a very short amount of time, 12 weeks, maybe as short as 8 weeks. And so if you're following people more closely from a creatinine standpoint, maybe urinalysis for microalbumin, you might be able to stay on the tenofovir backbone without observing clinical toxicity. And to my knowledge at this stage, although this drug interaction has been observed, I'm not aware of any reports that have suggested that patients have experienced adverse events remaining on their tenofovir backbone. And so if you don't have a lot of choice, I probably would do that myself. So I'm going to pass it over to Junine for the next part of the talk, and then we'll talk about our future regimens in a second.
I don't know if Mark realizes, I think I have the easier task for this. My section's pretty short. He had mentioned already at the beginning that because of the lack of P450 involvement with sofosbuvir and ledipasvir is that we don't anticipate a lot or expect a lot of interactions, and really what we're faced with is a couple of mechanisms of interactions at the level of the intestine. So one of them, I'm just going to review a little bit about absorption. So first looking at food and then the effect of acid-reducing agents. So the absorption of sofosbuvir and ledipasvir, it's been evaluated in a study in healthy volunteers, and regardless of the content of the meal, whether it's moderate or high fat, it had no effect on ledipasvir absorption, nor did it have a clinically significant effect on sofosbuvir exposure, which was increased, I think, about 60 to 90%, depending on the actual meal. So it's very easy medications to use, like both sofosbuvir and then sofosbuvir in combination with ledipasvir. Now, On the other hand, like Ledipasvir itself has a pH, its solubility is pH dependent. So with the use of acid-reducing agents for heartburn or ulcer treatment is that you have to be very careful about the dose and the specific timing, and the manufacturers come up with very specific timing with regards to when to dose and what to dose, how to dose acid-reducing agents, which I'm just going to quickly review with you right now. So we'll start off with the antacids, which are things like calcium carbonate, aluminum or magnesium hydroxide, which are in common over-the-counter medications like Tums, Rolaids, or Maalox, and these should be separated from Sofosbuvir, Ledipasvir by at least 4 hours, either before or after, to give it kind of this 8-hour window around it. And notice that it really is specifically for the combination product, the Sofosbuvir, Ledipasvir, and for patients who are taking Sofosbuvir, for example, for genotype 2, that wouldn't be a concern. Moving on to the H2 receptor antagonists, which are a bit more longer acting, a little bit more powerful agents for treatment of reflux or heartburn, and these include agents such as famotidine, nizatidine, or ranitidine, or maybe you might know them by brand names such as Pepcid, Axid, and Zantac. And so these also have to be administered very specifically, either at the same time as your Sofosbuvir, Ledipasvir, or 12 hours apart, and not to exceed doses equivalent to famotidine 40 milligrams twice a day. And where this recommendation has come from is, it was a single-dose crossover study in healthy volunteers, and they've kind of followed exactly, they provided this kind of guidelines, and you can see on the right there that it had very minimal impact on Sofosbuvir or Ledipasvir exposure, whether it was given at the same time or 12 hours apart. For those who are not used to, I guess, prescribing or using famotidine, is that, and because I had to look this up, it's like, what is an equivalent dose to famotidine for those who are used to using ranitidine or nizatidine? I think it would be like an acceptable comparable dose would be ranitidine 150 milligrams twice a day or 300 milligrams once a day, because famotidine is actually reasonably potent, and that would apply to the same to nizatidine 150 milligrams twice a day or 300 milligrams once a day. And then last but not least are the proton pump inhibitors, and those include more than these agents, but pantoprazole, omeprazole, or rabeprazole, like Pantaloc, Tecta, Losec, and Periot. And these agents should be taken at the same time as Sofosbuvir, Ledipasvir, but on an empty stomach. But it shouldn't be administered prior to the soft lead. And it should not exceed a dose equivalent to omeprazole 20 milligrams. And sorry, there was a bit of correction there. This was it was actually multi-dose omeprazole, but single dose of the direct-acting antiviral studies. There were 2 studies, and you can see that given 2 hours before Ledipasvir is that there was a decrease in Ledipasvir exposure by 42%. When given at the same time, it had a very minimal impact on Ledipasvir exposure, so hence the take it at the same time. Just to touch on, I guess, equivalent dosing, if you're, once again, maybe we're from a pharmacare perspective, if you need pantoprazole 40 milligrams or rabeprazole 10 to 20 milligrams, so it would be a reasonable alternative. So beyond the solubility issue is then that really the other mechanism that is a potential for interaction for these agents is actually intestinal efflux transporters and the effect on those transporters such as P-glycoprotein and breast cancer resistance protein, PCRP. And so both Sofosbuvir and Ledipasvir are substrates of those 2 efflux proteins, so basically kind of shunts, prevents drug from being absorbed by flipping them kind of out at the intestinal level. And medications that actually increase expression of these transporters in the intestinal lining are actually not to be administered with Sofosbuvir Ledipasvir for this reason. So these are potent inducers of P-glycoprotein. Listed below there are the older anticonvulsants, carbamazepine, oxcarbazepine, phenobarbital, and phenytoin. Also, there's the herbal antidepressant, St. John's wort, and then the rifamycins, rifabutin and rifampin. And although most of these are based on in vitro kind of effects on P-glycoprotein, there was some PK data with rifampin which showed that administration of rifampin decreased Ledipasvir exposure by 60% and Sofosbuvir exposure by 72%. So on the flip side, rather than that, sometimes the actual DAA or the actual Hep C drug could be actually the perpetrator or the cause of a drug interaction or a potential drug interaction. And I have to say that I have to stress that these are potential interactions. So Ledipasvir, knowing that it also is an inhibitor of the intestinal transporters BCRP, and which may cause an increase in digoxin levels by inhibition. And so the recommendation by the manufacturer is actually to monitor the digoxin level after initiation of Sofosbuvir Ledipasvir. On the other hand, too, they also have a very cautious recommendation to actually avoid rosuvastatin as well. And I couldn't find any actual PK data or cases of toxicity that have been reported, but also there's a concern that Ledipasvir may also increase rosuvastatin and increase the risk of myopathy or rhabdomyolysis, and you may wish to withhold that. Because treatment sometimes is only like 8 to 12 weeks, and if it's for primary prophylaxis, then you may opt to hold the medication. So this is something that was been recently reported. It was a Health Canada warning that came out earlier this month. It was very unexpected, and there were 9 cases, I guess this was post-marketing, 9 cases of very serious symptomatic bradycardia in patients taking amiodarone with either Sofosbuvir and Ledipasvir, or Sofosbuvir plus another direct-acting antiviral, but not Sofosbuvir with pegylated interferon or Sofosbuvir ribavirin. And this resulted in 1 fatal cardiac arrest and 3 cases actually requiring pacemaker insertion. And for those who don't know what amiodarone, it's a class 3 antiarrhythmic agent used in refractory ventricular arrhythmias. It's a very interesting medication. It's very toxic. It has numerous drug interactions itself, but this wasn't necessarily anticipated. The onset of most of these cases was within 24 hours, but I think 3 cases were up to 2 weeks. And it's unclear from a mechanism standpoint what this interaction is. Right now, I think they're exploring that, but some potential risk factors for these individuals were the use of beta blockers, the fact that they had advanced liver disease, and obviously cardiac comorbidities. And it's recommended to avoid this combination if at all possible, but because of its very long half-life, amiodarone, it has a half-life of like 60 days on average, is that this should be discontinued or addressed well before thinking about Hep C therapy with Sofosbuvir plus one of the other DAAs, and so that's about 3 months prior to initiating treatment. If you cannot avoid it, then they recommend actually inpatient cardiac monitoring for 48 hours and outpatient monitoring for 2 weeks. It's a pretty complicated situation. And this is not a drug interaction, but I thought it would be important to kind of maybe share with you, I guess, the concern with Sofosbuvir and Ledipasvir potentially in renal dysfunction. So you know that really when the larger clinical trials, they really only enroll patients who have normal renal function, and you know that in real life that a lot of people don't. So this is just actually some looking at actually exposures. And they actually don't anticipate and did not see any changes in Ledipasvir, but knowing that Sofosbuvir actually has is metabolized, and it has the major circulating metabolite there on the right, you can see that in severe to an end-stage renal disease is that the metabolite exposure is increased anywhere from 5-fold to 20-fold. And so this is what the manufacturer recommends right now is that you don't use the medication in severe renal impairment. And there's ongoing studies right now to look at whether or not actually using either that dose or other doses is safe in this situation. Okay, so I'm going to pass it back to Mark.
So one of the other combinations that we think is going to go through its common drug review later this year and might be available, we'll see certainly maybe through third-party coverage while we wait to see what Pharmacare decides later this year, is going to be one of the other combinations of DAAs. And this we'll call the 3D regimen because it actually combines 3 different targets from each of the sites that we looked at. So NS5A inhibitor, a protease inhibitor, and an NS5B polymerase inhibitor. The thing here that makes it a little bit more complicated from an HIV standpoint is that the NS5A, the protease inhibitor, the NS3-4A protease inhibitor, is itself requiring boosting with ritonavir. So it's a very similar concept to HIV protease inhibitors. This particular hepatitis C protease inhibitor also needs to be boosted for pharmacologic reasons with ritonavir. So it's going to be co-formulated with ritonavir as part of that particular regimen. And so this combination has been evaluated, obviously, in mono-infected patients, but they also have completed 1 co-infection study. I think another co-infection study is coming up, looking at 12 versus 24 weeks of therapy. And overall, again, very similar to what we saw with the Sofosbuvir Ledipasvir outcomes, the SVR rates here are very, very, very encouraging again, and very, very similar to what we're seeing for mono-infected patients. So we're looking at outcomes overall in the 90 to 95% SVR range. In this particular study, you had some limitations in terms of the antiretrovirals that you were allowed to be on. You were allowed to be on unboosted atazanavir because obviously the atazanavir is not being boosted by the ritonavir component of the Hep C co-formulated tablet, and you're allowed to be on an integrase inhibitor in this trial, namely raltegravir. And so in terms of their drug-drug interactions, because ritonavir is a component of their regimen, there are some issues that we have when we look at how we might choose to use this combination in individuals who are co-infected. So at the moment, it seems certainly quite complicated to use it with an NNRTI, such as efavirenz or pivirine. Kaletra may not be possible as well because Kaletra already has ritonavir as part of that co-formulated tablet, so you're going to end up giving a lot of extra ritonavir. And as we said in the trial that was performed, integrase inhibitors were not an issue, and atazanavir as a protease inhibitor could be administered in combination with the morning dose where the ritonavir is based, so you don't need to use extra ritonavir. So if you were to treat somebody, you would stop their ritonavir while they went through this particular treatment regimen. The other caveat that you have to keep in mind as compared to the other regimen that we looked at is you cannot treat an HIV-naive individual. So if you have a patient that's naive to HIV therapy, this would be a particular problem for us because here if you're treating their hepatitis C, you're going to be exposing them to ritonavir monotherapy, and this may be a risk factor for developing HIV drug resistance. And so in a situation where you're contemplating using this regimen, you would have to make sure their HIV was well treated before you moved ahead to treat them for their hepatitis C with this particular combination. From this standpoint, I think one of the other things we have to look at are the potential other drug interactions with other targets. So here it could be the CYP450 system, as we know from ritonavir, some other transporters and glucuronidation pathways. And so I'm going to actually give it to Junine for the last 2 minutes so we finish on time to remind you about ritonavir and all the things that we have to worry about with those drug interactions. And then we'll be happy to take some questions.
You're doing well. You're taking over my slides. Anyways, which is fine. You're doing great. Yeah, so 3D is, I guess if you work in, because we work in HIV, it's that actually a 3D regimen is actually not as daunting to us as it would be, I think, to other individuals because we're quite used to dealing with drug interactions, including ritonavir. But the good thing about, I guess, what 3D is, and is because it's a combination of 3 different medications plus ritonavir plus ribavirin, is they've actually done quite extensive drug interaction studies with, because it involves not only the cytochrome system, but glucuronidation and multiple transporter pathways, as then they've done extensive drug interaction studies. And they've actually have, if you look, I couldn't put all of them on here, it would take quite a few pages to get, they actually have quite specific recommendations with regards to dosing of medications. So I think is quite helpful. tried to cover all, I guess, like the major medications that are often used in hepatitis C patients, and also medications that are also substrates of those particular pathways that the medication's involved with. So you can see that there's specific recommendations here. I won't go through them in detail. So I think I'm just going to, we'll conclude then here, is that just going back to where, so Sofosbuvir, Ledipasvir, that's also known as Harvoni, and Sofosbuvir, which is Sovaldi, those both have those are available to us now. They have minimal drug interactions with antiretroviral therapy. As Mark mentioned, that caution, you have to exercise caution when using tenofovir with the Sofosbuvir, Ledipasvir combination, especially with PI-based regimens, and there's little positive data with Stribild, which is the cobicistat-elbapentecavir regimen. If it's possible, you can adjust the regimen, or you could monitor closely for any tenofovir adverse effects, especially since therapy for hepatitis C may only be 8 to 12 weeks for most individuals. With regards to drug interactions, there are a few, but it's important to review the dose and timing of acid-lowering therapy to ensure there's optimal absorption of Sofosbuvir, Ledipasvir, and avoiding those really potent inducers of, it seems like they induce everything, P-glycoprotein, and amongst other things, and so that includes St. John's wort and rifampin, the older anticonvulsants. And just a little statement there that noting that the 3D regimen, which contains ritonavir, really has numerous drug interactions and contraindications. You really have to consult like a resource. I think it's something that definitely is a very important step when considering that combination. So there should be a really very systematic approach to drug interactions before a patient is starting therapy. Is you want to make sure you have a complete medication history and like non-prescriptions, everything. And you want to screen for interactions using a really reliable hepatitis C drug interaction database. It's like constantly changing. It's complicated. It's quite specialized. And there could be different ways to manage depending on what the problem is, but it could be as much, maybe as little as a dose adjustment, or actually changing the drug. In certain circumstances where the medication may be non-essential and there's potential for interaction, they may consider holding it. And also, I guess maybe there was a lesson learned from the amiodarone story, is that monitor for unexpected effects with drugs with a narrow safety window. For example, like the digoxin and then the amiodarone story. And I'm just going to leave that there on the screen. And these are two very good hepatitis C drug interaction databases. The first one is Canadian from our colleagues in Alice Singh in Toronto, and also the other one is the Liverpool HIV Pharmacology group, and they're excellent websites and resources for you.